Hello, very good evening to everyone. I am Dr. Shaina Goyal and I welcome you all to today's educational series on lung cancer. So as we all know, the management of metastatic non-small cell lung cancer has undergone a paradigm shift over the last decade. Back then, the question was whether to treat this patient of metastatic non-small cell lung cancer or not, or just to offer him best supportive care, knowing that these patients have a poor prognosis and median survival of just 6 to 8 months. However, today, the question is completely different. It is which treatment to choose for our patient. With better understanding of lung carcinogenesis, the advent of targeted therapy, immunotherapy, and our patients living longer with a better quality of life, it is very important to be aware of all the updates and to choose the right treatment for our patients. So therefore, today we have for you a fantastic lineup of speakers, as we can see here, who would take us through the current management in lung cancer and also discuss the future directions. With this, I would like to start with our first speaker, and I would invite upon Dr. Ashok Vaid, sir, the chairman of Medical and Hemato-Oncology in Medanta. Sir would be discussing about the current management of lung cancer as we know in 2022.
So, good evening, everyone, and thank you, Shaina, and thanks to everyone who have registered, and thanks to all the faculty right at the beginning and for energizing our efforts, and thanks to our knowledge partners and supporters. I'm not going to make a formal presentation because there is a lot to come by, and all that I would say is reiterate the point what Dr. Shaina has already said, that till the year about 2000, we just had to choose the partner drug, and then the platinum was decided, and out of the 3 drugs, gemcitabine, paclitaxel or docetaxel, vinorelbine, out of the 4 drugs, we chose a partner and treated these patients with very dismal outcome. And come the era of EGFR, which was the first mutation we realized, and a plethora of drugs to target the EGFR thereupon, the whole scenario changed. And we remember the landmark trial by Tony Mock, which showed us that chemotherapy versus gefitinib, there was a betterment in the progression-free survival. Everything changed. The whole practice changed and then changed forever. And the next turning point was the understanding about the other markers. Principally came the ALK, then ROS1, and a host of other mutations. And today we would be talking about the exon 14 skipping mutation and the other targeted therapies, principally the ALK directed therapies and others, and followed by a panel discussion which Dr. Nagendra is going to moderate. So as Dr. Shaina said, that today we are actually choosing the treatments based on the outcome of whether the NGS or whatever platform one would use to understand the biological nature of this disease. And therefore, it becomes imperative for us to plan the biopsies, execute the immunohistochemistry, and take upon the further analysis of the biopsy in a very diligent and a stepwise or a very concerted manner, so that the tissue is optimized and the outcome of the analytical process is satisfying, so that the right treatment is chosen. With that, I think I would stop here and hand over the proceedings back to Dr. Shaina to invite the next speaker. Thank you, everyone, once again, and back to Shaina.
Thank you, sir. Thank you for paving the way for an exciting evening that we have ahead. So for the first talk, I would call upon Dr. Jyoti Vadhwa ma'am. So we know the ALK was one of the second targeted therapy. The ALK inhibitors were the second targeted therapy that were approved for non-small cell lung cancer. And from the first drug, crizotinib, in 2011 to today, when we have 5 different drugs, I think it is one of the most complex and confusing for the young oncologists to choose which ALK inhibitor to choose for our patient. So ma'am would put some light on this. I welcome Dr. Jyoti Vadhwa ma'am, Associate Director of Medical Oncology at Medanta Cancer Institute.
Thank you, Shaina. So let me share my slides. I hope they are visible now.
Just put it full screen, ma'am.
It is full screen and
Yes.
Yes.
yeah. Okay. So good evening, everyone. We are all practicing in the era of precision oncology, and today I'm going to talk about updates in the therapeutic landscape for ALK-driven non-small cell lung cancer. So we know that lung cancer is a heterogeneous disease. The diagnosis is not just limited to the histological diagnosis. We now label a patient with a molecular diagnosis. ALK positive subgroup is in fact a distinct subset of non-small cell lung cancer. And the treatment of this subset of non-small cell lung cancer has really evolved over past many years. Ever since the discovery of ALK gene rearrangement in non-small cell lung cancer way back in 2007, we have now 6 approved ALK inhibitors. The journey started with approval for crizotinib with the profile trial, initially in earlier treated non-small cell lung cancer patients, moving on to the first line place. And this crizotinib approval was subsequently followed by development of 4 second generation and now 1 third generation ALK inhibitor. And I'll take you through some landmark trials which got them the respective approvals in first line treatment. So this was the study Profile 1014, which was a randomized trial which randomized patients 1:1 into crizotinib versus pemetrexed, cisplatin, or carboplatin. And these patients had no prior chemotherapy. So this was the study which established superiority of ALK inhibitor crizotinib over chemotherapy in terms of not only response rates, but also improvements in the progression-free survival and also the overall survival. The quality of life was also better with the ALK inhibitor compared to the chemotherapy arm. However, crizotinib has a drawback. This drug gets actively exported back across the blood-brain barrier into the bloodstream by P-glycoprotein, and therefore making the CNS a frequent site for relapse in crizotinib-treated patients. The other issue is the development of secondary mutations leading to its subsequent ineffectiveness or resistance to the treatment with crizotinib. In fact, now we have been able to identify the various types of mutations and their sensitivity or resistance to various available ALK inhibitors. And sometimes in our practice, we do choose an agent based on these specific mutations. Also, there are some compound mutations which in fact warrant resensitization with an earlier used ALK inhibitor, namely crizotinib or alectinib, as the case may be. The second generation, the first addition to this subgroup was ceritinib, and this was the basis, the ASCENT-4 trial, which was a phase 3 trial of first-line use of ceritinib versus chemotherapy. And this trial again documented the superior efficacy of ceritinib in comparison to chemotherapy in not only those patients who did not have brain metastasis, but also in those who had brain metastasis at diagnosis. The intracranial response with ceritinib was an impressive 72% compared to just 27% with chemotherapy. So this trial of ceritinib established the role of the second generation ALK inhibitor based on improvement in the response rate, a PFS benefit, and a numerical improved overall survival. The toxicity was mainly GI, but manageable. However, both these agents, namely crizotinib and ceritinib, have a big drawback that they both, though are able to cross the blood-brain barrier, but they get exported actively across the blood-brain barrier into the bloodstream, making CNS a sanctuary site for tumor growth. Crizotinib treated patients, almost 46% developed brain metastasis at progression, and 42% of those treated with ceritinib developed brain mets. And this led to the continued efforts for a better agent for treatment of these patients. And then came another second generation ALK inhibitor, namely alectinib, which was a much more potent inhibitor of ALK and also was able to target many more resistant mutations. This also had led to a better CNS penetration and higher efficacy in terms of brain control. The alectinib got its approval as the first-line treatment of ALK-positive non-small cell lung cancer patients based on three important phase 3 studies, namely JLX, LX, and Alicia. JLX comprised of Japanese patients, LX comprised of patients who were treatment naive, and Alicia was of patients from Asian subcontinent who had ALK-positive non-small cell lung cancer. So I'll be talking about LX study. This was a randomized phase 3 trial of alectinib versus crizotinib, with the PFS being the primary endpoint. And this established superior efficacy in terms of improved PFS with hazard ratio of 0.43. 34.8 months was the median PFS versus just 11 months with crizotinib. Alectinib as first-line treatment did reduce the risk of CNS progression as well. The overall response rates were, though good in both the arms, 75% with crizotinib and 83% with alectinib. However, to note here is the duration of response, which was thrice with alectinib when compared with crizotinib. The updated analysis has presented the 5-year overall survival, and herein it was reported that alectinib as first line had more than 60% overall survival at 5 years, which meant that 6 out of 10 patients were still alive on alectinib at 5 years. The toxicity was manageable and it was well tolerated over its long-term use. And thus, alectinib became the preferred first-line treatment for ALK-positive non-small cell lung cancer because of its improved and impressive PFS advantage, protection against CNS metastasis, and also the treatment capability for the brain metastasis. This is the only ALK TKI to have demonstrated a meaningful benefit in the overall survival as well. And in addition, it has manageable toxicity profile. Then came another second generation ALK inhibitor, namely brigatinib, which was studied in this ALTA first line trial. Again, a phase 3 trial of brigatinib being compared with crizotinib in escalating dose of 90 milligrams a day for 7 days, followed by doubling of dose to 180 milligrams a day. And PFS again was the primary endpoint. And this study also documented improvement in the median PFS and the overall response rates with brigatinib when compared to crizotinib. And it was also effective in control of CNS metastasis. And obviously those without it also did well. We have a third generation ALK inhibitor, namely lorlatinib, which after initial phase 1 and phase 2 studies documenting its efficacy, quickly moved on to this phase 3 trial, the CROWN study. And I'm sure the next subsequent speaker is going to talk about this study in detail. But just to tell you briefly, this compared lorlatinib in the standard dose with crizotinib, 1:1 randomization, and documented improvement in 1-year PFS rates. And they were impressive, 78% versus 39% PFS at 12 months. Improvement with the lorlatinib. The hazard ratio was 0.28, 72% reduction in the risk of progression with lorlatinib. The subgroup analysis revealed that all the subgroups in the study seemed to benefit with lorlatinib. The response rates were good, higher, 76%, and the duration of response was not estimable at the time of reporting of this study. The intracranial response was also an impressive 66% with lorlatinib compared to just 20% with crizotinib. And again, these responses were well maintained. A suggestion of improvement in the overall survival is also established. The side effects, hypercholesterolemia and hypertriglyceridemia, we have all experienced in our practice. And the other additional side effect is the neurocognitive decline, which can be problematic in some patients. So this study, CROWN study, did document longer PFS and improved the response rates, including intracranial responses, with improved global quality of life. This slide sums up the approved ALK inhibitors available to us, and the studies are still ongoing. There are efforts ongoing to see the combination of ALK inhibitors with chemotherapy, with targeted agents such as VEGF inhibitor bevacizumab. However, the number of patients in these trials is very limited. Some new agents are also under study. I would wish to name one, ensartanib, which is an oral ALK inhibitor, which in this trial, phase 3 study, has been found to be superior to crizotinib in ALK-positive non-small cell lung cancer patients. The study, however, had 290 patients and documented improvement in the median PFS and also the intracranial response rates. So the results recently published just 2 months ago in JAMA Oncology. And this is also an agent to look forward to. So just to sum up my talk, this is how the landscape of treatment of ALK-positive metastatic non-small cell lung cancer looks in the current era. The studies are looking at the combination of ALK inhibitors with various immuno-oncology agents, and the results are much awaited. However, we must remember that the first-line decision-making for these subset of patients will also be based on patient preference, their financial status, the toxicity profile, understanding of resistance mechanisms, and also availability of long-term follow-up data. As the time extends on these studies and trials, we'll get more and more knowledge about the long-term efficacy and tolerability data. So I'll end my talk here, and thank you for your attention.
Thank you, ma'am, for this comprehensive talk. And so beautifully, you have told us the evolution of treatment in ALK rearranged non-small cell lung cancer. And another drug also you have told us, which is going to add to the confusion of which agent to use for these patients. The most recently approved lorlatinib, I think, needs further discussion. And I invite upon Dr. Priya Tiwari, ma'am, Senior Consultant Medical Oncology at Artemis Hospital, for our next talk on lorlatinib in the management of ALK rearranged non-small cell lung cancer.
Sir, Dr. Priya Tiwari is just about to join, so we can take any couple of questions with ma'am, I think.
Yeah, I think that would be good. So if there is anyone who has any question, they can even write it in the chat box. We can take it up, or anybody can raise a hand. So, Jyoti ma'am, can I ask one question till Priya ma'am joins?
Yeah, fine. Yes.
So, ma'am, how do we choose between now lorlatinib and alectinib? Because I think these are the two drugs which have a good enough safety profile and have a good brain penetration.
So I would prefer to use alectinib as the first-line treatment. I think the data is more robust. My comfort level with whatever experience I have with the toxicity profile of alectinib, I'm comfortable. The side effects aren't too many. They are easily manageable. Lorlatinib, we know dyslipidemia, but more so, the neurocognitive side effects with lorlatinib may be troublesome in some patients. The other factor is how to, best sequence. So we really don't know as of now as to if we choose to use the third generation lorlatinib as the first line treatment, what do we offer the patients on its failure in the second line and beyond. So based on these reasons, I would prefer to choose alectinib as my first line treatment and not lorlatinib.
Thank you. Any other questions we have?
I think if we have the speaker next to Dr. Priya, if someone is available, we can
Priya has joined.
Reschedule the.
Yes, Dr. Priya has joined.
Is joined?
Hello, sir. Yes, I'm here. I'm so sorry.
Okay. Let's go ahead.
So I think ma'am has just joined. Ma'am, I invite you. I'm Dr. Shaina Goyal. I invite you for this next talk. We have had a very comprehensive talk by Jyoti ma'am, which has covered the evolution of treatment in ALK rearranged non-small cell lung cancer. However, the recently approved lorlatinib needs further discussion. And please, ma'am, could you?
So I'll just share my screen. Thanks for the opportunity. Thank you, Dr. Vaid. So I think the slide deck is visible.
Yes, ma'am.
Yes. So I'll just start lorlatinib. Yes, it's a new molecule and a very promising molecule. So we'll be just discussing in the management of ALK rearranged non-small cell lung cancer. So we do understand that lung cancer is one of the most common cancer all over the world. In India now, we see a lot of lung cancers in females also. 5-year survival rate is around 25% for all non-small cell lung cancer patients and only 7% for those diagnosed with distant metastasis. The unfortunate part is that the many patients come in the advanced stage because this is one of the cancers which is usually missed in the early stages. And the lung cancer screening is yet not a standard as a part of the standard routine screening recommendation across any part of the India. The incidence is rising in the females also. It might be just because of the risk factors, also because of the increased longevity of the population, and maybe certain risk factors such as increasing incidence of smoking and this pollution. So a very important thing is that we are finding more and more targets. The world is moving towards the precision medicine, and lung cancer is actually is one such cancer which is shining compared to all other cancers, because the highest number of targets that we can target with any treatment are there in the lung cancer. And one of the important leaders in the list is the ALK rearrangement. So ALK gene rearranged lung adenocarcinomas, this was a very important study just to show the prevalence. And what we find that ALK gene rearrangement in the lung adenocarcinoma is the second most common, around 1.6 to 11.7% of all non-small cell lung cancer patients. At some point of time, we were just testing adenocarcinoma patients, but many of the guidelines also say that a small percentage of squamous cell carcinoma patient might also have ALK mutations. And again, you can test in the squamous cell carcinoma also, and where you can find if the ALK rearrangement, you can do the targeted therapy. So after EGFR, ALK rearrangement are one of the very common mutations in the patient exhibiting mutations. So usually around 5% of all non-small cell cancer patients. And if typically usually see in adenocarcinoma, never smokers or light former smokers tend to occur in younger patients compared to the EGFR subset. You have FISH, we have methods of, especially this various methods of detection, such as we have FISH, we have the various NGS platforms, and we also have ISC markers available. So the kind of mutation that we are looking for is EML4 ALK mutations, which are actually mutually exclusive from EGFR mutation. But we do know by our experience that in a occasional patient, we do see these coexisting mutations. And there, always it's a challenge to decide how to treat such patients. So what exactly is EML4 ALK fusion in non-small cell lung cancer? A type of gene rearrangement called as inversion that occurs when a chromosome is broken in 2 places and the resultant piece of DNA is reversed and reinserted into the chromosome. A small number of non-small cell lung cancer patients have an inversion of chromosome 2, which causes the fusion of an ALK gene with an EML4 gene, resulting in EML4 ALK fusion protein. It was first initially reported in 2007, leading to constitutive activation of the kinase domain, and thus acting as a driver mutation in a subset of lung cancer patient. So the story started in 2007. And once the target was found, we found a targeted therapy with crizotinib coming in picture as early as 2012. And we were very happy with the responses. One of the very long PFS was seen with crizotinib in this subset of lung cancer patients. Then subsequently, we got the second line ALK inhibitors, such as ceritinib, alectinib, brigatinib, and now they also are one of the standard line of treatment for patients with ALK mutations. And then subsequently, the drugs, the one used in second line were approved for the first line, and latest in the list is lorlatinib, with lorlatinib gaining approval in frontline in 2021. So important thing is that there is a lot of unmet need in lung cancer, and more so for ALK positive. Because we have patients who are predominantly young. The ALK patients are generally younger. Median age is around 50 years. So even if you're offering them a median survival of 3 years or 4 years, it's actually still less compared to what if the disease would be occurring at a much older age. CNS metastasis occur in 20 to 40% of untreated ALK positive patients and is a significant challenge associated with poor prognosis. I recently had a patient who was actually stage 3 lung cancer with ALK positivity, and he actually developed brain metastasis, single brain mets after 2 years of follow-up after CTRT. Also, emergence of resistance mechanism, including ALK resistance mutation in CNS metastasis due to inadequate penetration of some current treatment options, continues to be a treatment challenge, even with the availability of second generation ALK TKIs. So there is a need for additional ALK TKI, that is untreated patient prevents the emergence of resistant subclones with improved CNS penetration. So lorlatinib is actually one such molecule which qualifies for many of these parameters. It is a selective ATP competitive, highly potent third generation ALK inhibitor and had excellent brain penetration. So what we see is 75% of the drug concentration can be seen in various CNS sites. So a molecule to address brain metastasis, it fulfills these criteria. So it has a potential to improve clinical outcomes with overall and intracranial activity in patients with previously untreated ALK positive advanced non-small cell lung cancer. In addition, upfront treatment with lorlatinib could completely suppress or at least significantly delay on target resistance, leading to more durable clinical benefit. So it was a rationally designed to address the unmet need in ALK positive patients with metastatic brain disease or with the patients who are having acquired resistance to the other ALK TKIs. So compared to crizotinib, lorlatinib had certain advantages, especially it has an effective CNS penetration and retention, binds with high affinity to most ALK resistant mutation. So this was the article which actually proved its further efficacy. First line lorlatinib or crizotinib in advanced ALK positive lung cancer patient crown trial. So the key eligibility criteria were the stage 3B4 ALK positive patients with no prior systemic treatment for the metastatic disease. And they took the patients of performance status 0, 1, and 2 as well. Asymptomatic treated or untreated patients. So untreated patients were also taken provided they were asymptomatic. They were randomized into 1:1 manner with lorlatinib versus the crizotinib arm, and the primary endpoint being PFS by the BICR. So a very important thing was that, yes, they took patients with performance status of 2, which are actually many times excluded from the trials, and they also took the patients with untreated CNS metastasis, provided they were asymptomatic. So out of the study was conducted across 23 countries. 296 patients were randomized from May 2017 to February 2019, 1:1 randomization to 149 and 147. So restaging with CT, chest abdomen CT scans, and the brain imaging every 8 weeks. In real life, we tend to do it every 3 monthly, but in most of their studies, they usually do 8 weekly staging this response evaluation workup. So as of March 2020, the interim data cutoff, 103 patients in the lorlatinib group and 31 patients in the crizotinib group remained on study treatment. Median duration of follow-up for the PFS was 18.3 months and 14.8 months respectively. So when we are comparing the baseline characteristic, the median age was slightly younger in the crizotinib age group, like it was 56 years compared to 61 years in the lorlatinib group. Females were around 56 to 62%. And yes, they were equal. There were a lot of participation across across white or Asians. And we do have patients with the smoking, never smoked, previous smoker or current smoker. So sometimes there was an old thought process that you should test only in patients with history of smoking, non-smoking, all those things. But here, now we know that yes, you should test all patients with advanced lung cancer. And yes, like I previously said, maybe in the squamous cell carcinoma also. Around 26 to 27% had patients with brain metastasis. And only a small percentage had a history of prior brain radiotherapy. That is 6% and the 7%. So when we compare the primary endpoint of PFS, we do see a marked improvement in the lorlatinib group. The HR is very impressive with 0.28. And that is what we can see by the separation of graphs also, favoring the lorlatinib group much over the crizotinib. So 12-month PFS rate was around 78% and in the lorlatinib group, and it was 12 months PFS in the crizotinib group was 39%. If we see PFS by the investigator, we again find that the results are resembling the blinded independent central review itself. And the 12 months PFS rate was 80% in the lorlatinib group and 12 months PFS rate was 35% in the crizotinib group, with again a very impressive HR of 0.21 favoring lorlatinib. And when we see the various subgroups, so irrespective of presence or absence of brain metastasis, ethnicity, performance status, age, sex, smoking status, and the histology, we see that yes, the drug is favored, the lorlatinib is favored over crizotinib when we are comparing the PFS across various subgroups. So when we talk about response rates, now we know that with TKI, whenever we are giving TKIs, we usually see stable disease responses as the most common kind of responses. But here we do see a subset of patients exhibiting complete responses in the lorlatinib group. And yes, the various degrees, the depth of responses is consistently higher in the lorlatinib or nearly equal to the crizotinib group. So what we see a longer PFS rate and few patients exhibiting CRs in the lorlatinib group. Now, most important parameter, because we understand that the lorlatinib has intracranial penetration, again, this trial showed that yes, the intracranial responders were much higher in the lorlatinib group compared to the crizotinib group. And if you talk about intracranial CR, we again see that the lorlatinib group exhibited marked improvement over the crizotinib group. So similarly, intracranial time to progression by BICR was better in the lorlatinib arm compared to the crizotinib arm. So again, just to reiterate that yes, the most important and the most favorable part of lorlatinib is yes, that the intracranial penetration is very good with the lorlatinib, and the drug has retentivity also in the brain, and it is showing that is reflecting in the long-term responses also in the lorlatinib group. Somehow we don't see much difference in the overall survival, but that might be because of the short follow-up and also because this is impacted by the second line and the beyond kind of treatment. Now, an important thing is whoever has used lorlatinib understand that maybe the side effect is slightly more in the lorlatinib group compared to the crizotinib group, but this might be also because as we are learning more and more how to use this drug, as we are gaining more familiarity with lorlatinib, we understand that yes, over the period of time, we will learn how to manage, and the predictability of the side effects as with our understanding will further improve. But here, as of now, we do see slightly more side effects with the lorlatinib. So if you talk about serious adverse events, it was 51 versus 39 in the crizotinib group. So the list of side effects are many with lorlatinib. A lot of side effects are purely biochemical in nature, in the sense that we see a lot of alterations, especially hypercholesteremia, hypertriglyceridemia, which could be like you are monitoring the levels and you are finding that these parameters are changing, and at some point of time you will need management which goes just beyond the dietary management. We do see edema, weight gains, and yes, an important side effect is cognitive effect, change in cognition, and I'll be just subsequently discussing this also. We understand the side effects of crizotinib. We see diarrhea, visual changes, GI side effects, all those things with crizotinib as well. But yes, sometimes the edema, and yes, a subset of patient might also have with the lorlatinib group pleural effusion also, and peripheral neuropathy. But most importantly, because the drug is capable of impacting the symptoms, you can have improvement in symptoms, and at some point of time, the side effects might become manageable. So overall, when you compare the global quality of life scores, you find that yes, the lorlatinib has more favorable impact over the quality of life compared to crizotinib. And since these responses are sustained, we understand that yes, these quality of life scores will be maintained in a favorable period, longer in the lorlatinib group compared to the crizotinib group. So the overall, what the trial concluded was that the lorlatinib resulted in significantly longer PFS, significantly higher overall and intracranial response rates, and improved global quality of life compared to crizotinib in first-line treatment-naive ALK positive non-small cell lung cancer patients, with lorlatinib intracranial response rates around 82% in patients with measurable brain metastasis, with a complete response rate of 71% and significantly longer time to intracranial progression. The safety profile of lorlatinib was similar to that reported in previous studies, and grade 3 and 4 adverse events were more frequent with lorlatinib than crizotinib. However, the majority were laboratory abnormalities. They were asymptomatic and readily managed. So the results support the use of lorlatinib as an effective first-line therapy for patients with advanced ALK-positive non-small cell lung cancer. The other important thing is, my slide deck is not moving. Is the time up?
No, please continue. Please continue.
Yes, sir. So there's some problem with the slide deck. Yes. So now the guidelines are actually recommending that the drug can be used in the first line. So there are two kinds of patient, whether you have the results available, the patient can wait, the symptomatic burden is less. So you can directly start the patient after the results are available directly on lorlatinib. Or yes, you can later on, if the patient has been started on chemotherapy, very well you can use them as a maintenance therapy, either a switch maintenance or interrupted maintenance, and put the patient on lorlatinib. So this is how the drug is now being used in the results are coming and favoring in the first line itself. The important thing is the management of hyperlipidemia. Now, what is important is, and that applies to all TKIs, most of them are actually substrate and they are metabolized through cytochrome P450. So you have to see what all concomitant medicines patients are taking, and you should have the patient should avoid polypharmacy. If you need a lipid lowering therapy, pitvastatin, pravastatin, or rosuvastatins are the drug to go forward because they have lower involvement with the specific CYP450 enzymes that can interact with lorlatinib. Importantly, so whenever a patient with hyperlipidemia, dyslipidemia comes to us, we are usually doing a lipid profile. At least I do lipid profile once in 3 months. But if such patients where you are finding lorlatinib-induced dyslipidemias or hypercholesterolemias, it's important that you should do a more close follow-ups for these abnormalities, and maybe 1 to 2 months after initiating treatment is the way to go forward. Then you can do a periodically monitoring thereafter. Advise patient that hyperlipidemia is managed and resolvable through lipid lowering therapy and or dose modifications. CNS effects include change in cognitive function, mood, and speech. So every time whenever there is a change in cognition, there could be two possibilities. One could be drug, and second could be disease progression. But you should not panic that the change in cognition is because of the disease itself. It could be very well because of the drug also. It is usually mild in severity, intermittent, and improves or resolves upon dose modification. So these ADRs were reported at a frequency of 39.7%, with 11.9% of the patient experiencing more than one type of the CNS effects. Baseline CNS metastases were present in 71.8% of the patient with CNS effects. So sometimes it's difficult to find out what percentage was because of what. A total of 24 patients required more than one dose modification as a result of CNS effects. 15 of these patients experienced resolution in these CNS effects. The median time of resolution of CNS effects was 12.5 days. So I would say it's a prompt resolution. Recurrences of CNS effects upon rechallenge at the same time and reduced doses occurred in 6 and 7 patients respectively. So you should not think that once the CNS effects are occurring, you should actually have to stop the drug and not reintroduce it. Sometimes upon the resolution, the drug rechallenge is very much an option. So these are the standard dose modification schedules, that is depending upon the CTCAE grading. So grade 1 means mild, so continue at the same dose or withhold dose until recovery to baseline. Rechallenge at the same dose or reduce dose by 1 dose. Grade 2, that is moderate, or grade 3, severe. Withhold doses until the adverse event becomes grade 1 and around that. So rechallenge at 1 reduced dose level by 25 mg. And yes, we understand for the grade 4, that is life-threatening or the urgent intervention wherever is required, permanently discontinuation of drugs should be done. So instruct patient and caregiver to report any changes in cognitive function, mood, or speech, and ask them not to panic. It's very important because they might think that what is happening. So it's very important that such patients' education is given and such side effects are noted. Thank you.
Thank you, ma'am. Thank you for your wonderful presentation. So I think before we proceed further, just a small question to you. What do you prefer in your clinical practice? Do you prefer lorlatinib after it has been approved now?
See, I'll prefer lorlatinib. Cost allows me to.
Okay.
Yes.
Otherwise, okay.
See, we had a trial of lorlatinib at our place. So we are very much familiar with the molecule. And yes, we are seeing long-term sustained responses, including like the intracranial responses. So it's a beautiful molecule. Yeah,
the intracranial, I think the CR rates are very high.
Very good.
Yeah. Okay. So moving forward to a, thank you, ma'am. Moving forward to a relatively newer targeted agent, which has been identified in non-small cell lung cancer, the MET exon 14 skipping mutation. And today we have a drug rather 2 drugs approved, 1 more approved recently, but we discussed first capmatinib that we have and available today, and I invite Dr. Ashok Vaid sir for the same.
Is my slide deck view?
Yes, sir. Yes.
Good evening, everyone. And I think let's switch gears and look at the other mutation, which is come into a sharp focus recently. And with the introduction of capmatinib, the promise of treating the MET exon 14 skipping and SCLC patients has become much brighter. And let's look at how this drug is unlocking the unmet medical need in this group of patients. Let me take you back to a little bit of basic sciences and refresh the memory. And in the interest of the postgraduates or the trainees who may be on the program, all that we wish to know is that there are sequences in a gene, the exon, intron, and exon. That is how it alternates. And the next slide will tell you that why we are discussing the exon, introns, and the exons out here. Because in the synthesis of the mRNA, the DNA splicing happens. And in the splicing, there is a section of the gene or the DNA which is removed. And this is removed by the chemicals called as restriction enzymes. And these enzymes are actually in plenty. They are in thousands. Now, how does the splicing happen? As I said, there is an exon, there is an intron, and there is an exon again out here. And then the 2 ends we know from our basic sciences, the 3' and the 5'. Now, to take the intron away, to splice this, there are ribonucleotides, the ribonucleoproteins, and there are 5 of them. They actually come into the fold of the intron, and they bring the 2 ends of the intron close to each other and take the intron away, bringing the 2 exons close to each other. Now, having known this, this story would happen in the synthesis of mRNA from a DNA to pre-mRNA to RNA, and how the splicing of the introns would happen, bring the exons together, and the mRNA would be created. Now, imagine there is a mutation in one of the introns out here. So therefore, the splicing doesn't happen. All it does is, instead of the intron, the exon 14 also is taken away, and exon 13 and 15 come together to call it as a skipping of exon 14. And this is the very essence of what we are going to discuss in the subsequent part of the presentation. So this is how the skipping of exon 14 happens. And besides the skipping of the exon 14, there could be actually many more possibilities. And the other possibility is about the amplification. The exon skipping can happen in about 3 to 5% of the patients, and the amplification can happen in about 1 to 6% of the patients. Fusion and point mutations are actually less common. They seldom happen. Now, once the MET exon 14 skipping happens, what does it mean? What does it entail? There is a specific error in the MET gene called exon 14 skipping, as we saw in the previous part of the presentation. Now, normally, the proteins, after their function is over, need to be broken down and discarded. And there is a protein called as the CBL, which helps break down the MET protein. Now, once the mutation happens, the protein cannot be removed. It prevents the CBL from binding, and therefore allows the MET to sit in the driver's seat, which turns the growth signals on, and these growth signals can lead to an unregulated growth of the cell, lack of apoptosis, and dysregulation of the cell. How can we test MET in the practice? PCR, IHC, FISH, as well as NGS. These are the platforms, and we know that IHC and FISH are generally not recommended. The PCR is also, we know, is a more DNA design dependent, and there are technical considerations as far as RNA is concerned. Same is true about NGS, and therefore the PCR and NGS probably are the best ways to go about. Now, in different solid tumors, we can see on this slide the expression of the mutation. And of course, the lung adenocarcinoma is probably one of the best known for this. And as I mentioned in the previous part, that up to about 3% of the patients can have the MET exon 14 skipping mutation, and 1 to 6% can have the amplification. So lung adeno and the two abnormalities, the skipping mutation and the amplification, can happen. Now, what happens if there is a skipping mutation? There is a worse survival. And according to the MET mutation, overall survival, one can see the MET positive versus MET negative. The survival curves are very well separated off. And the overall survival in the adenocarcinomas, in the wild type versus the MET mutation happening. And one can see that there is a difference in the outcome. Now, not only that, we know that broadly the mutations, once they happen, even in the face of a PD-L1 positivity, the outcome with the treatment with the checkpoint inhibitors is not great. So therefore, we rely majorly on the mutation or the gene abnormality which might be present, and be that one of the EGFRs or ALK or ROS1. So same is true about the MET14 skipping mutation. So, and there is some data available that the median progression-free survival was about 1.9 months versus overall survival of 18.2 in the same group of patients who were treated with the checkpoint inhibitor. Also, some retrospective data that overall survival for stage 4 patients who never received a MET inhibitor versus who received a MET inhibitor, one can see 8.1 versus 24.6 months, very impressive. So the MET inhibition actually is a well proven and a strong area of therapeutic intervention. Now, of course, in those patients we were treating earlier with the crizotinib and some of the other MET inhibitors, which are not as selective. And one can see that why I say that is that the IC50 for crizotinib and cabozantinib is much higher as compared to capmatinib, and one can see for civoltinib and tepotinib also the IC50 is higher. So it's a very profound inhibitor and also crosses the blood-brain barrier, showing preliminary brain activity. And I would show you data that there were responses in the brain as well in the phase 2 trial. And that is the geometry mono 1 study. And looking at the methodology, don't get intimidated by the number of arms, which is shown here. This was a multi-cohort study. But I draw your attention to the center of the cohorts. The cohort 4 was a pre-treated patients with MET14, regardless of the copy gene numbers, and cohort 5 was the treatment naive. So we will focus our attention on these two cohorts of the 5B, the MET14, regardless of the copy gene numbers, and the cohort 4, the pre-treated. There were two later cohorts, the expansion cohorts, and they were again the pre-treated and the treatment naive. The difference was that the earlier cohorts, they received the drug on an empty stomach, but the second cohort, the expansion cohort 6 and 7, received the drug regardless of meal intake. So this was actually to test the hypothesis. And of course, you know, that's the short summary in the next slide, that there are two different cohorts of no therapy, no previous treatment. That is the cohort 5 and 7, and the other cohorts did receive treatment earlier on, and they were stratified according to the copy gene numbers, the mutations, or the amplification. The prime endpoint, mind you, this was a phase 2 setting, though, so the numbers represented here should not mislead us, because this is a typical phase 2 numbers. And the phase 2 setting, looking at the overall response rate and the duration of response, and many other secondary endpoints. So the 2020 publication in NEJM on the same trial. Now, what was the efficacy data? Looking at the baseline characteristics, what comes to the fore is that more women are actually represented. So more women would be expressing this mutation. Never smokers, again, typical something like the EGFR and the ALK1. Also, about 60% of the patients not being smokers, or about 30 to 40% being ex-smokers. And of course, histology adenocarcinoma, but the point brought out here is that even squams would also exhibit the mutation. And there were some patients with stable brain mets or who had not progressed in the last about 4 weeks prior to randomization. They were also taken up in the trial. And one can see the stratifications based on the copy gene numbers and other parameters. So prior therapies, obviously this was not any drug was available prior to capmatinib. So these patients are obviously treated with chemotherapy on various lines, first line, second line, and some of them on single agents, and a small percentage of these patients receiving the targeted BEV treatment as well. Now, look at the best overall response, and pre-treated, that is the cohort 4. I draw your attention to the bottom part of the slide, that is the overall responses. So even in the pre-treated, look at the responses, 40% plus, both by the independent review as well as the investigator, almost a concordance in the figures, and the disease control rate at the stable diseases also climbs up to 75% plus, which is very, very impressive, very astounding, especially in the pre-treated group. Now, what about the treatment naive? That was the cohort 5B, and the overall response is 60% plus, and at the stable disease, it climbs to 90% and above, never heard of in a targeted setting, that such impressive responses in the treatment naive patients. And the depth of the responses as observed, cohort 4 is the pre-treated, cohort 5 is the treatment naive, and one can see the depth of responses very well depicted out here in both the groups. Duration of response, the duration of response was median was 9.7 in the pre-treated, 12.6 in the treatment naive, and that's how depicted here. And the progression-free survival 5.4, more than doubled in the treatment naive, that is 12.4 months, very, very impressive. And the swimmer plots for the rapid and the durable responses across both the cohorts, one can see that the overall response is partial and the duration of response actually being depicted. So the drug is impressive in terms of the onset of the responses, in terms of the duration of responses, progression-free survival, and the overall responses climbing to 90% and above. And not only that, even in the brain, there were responses. 12 of the 13 patients had intracranial disease control, and 4 had complete resolution of all brain lesions. So this is a drug which is impressive in the brain as well. Deep responses, as I showed you in both the cohorts. Now, there is some data available for the 4 cohorts, as I mentioned, the cohort 4, cohort 5B, and the 2 expansion cohorts 6 and 7. And what one can see that the overall responses do stay 60% above. The disease control rate climbs to in cohort 7. This is the previously untreated, regardless of food intake, climbs to 100%. So everybody getting a response, some sort of a response or a stability of disease, whoever takes this drug, it just can't get better than that. And even in the second line, the responses are very, very impressive, 40 to 50% and 70% above, climbing up to about 90% in the cohort 6. That was the pre-treated cohort. Now, these patients respond very quickly because the first assessment in the trial was at 2 months. So within 2 months, there were responses which were seen. And as I've shown you, the duration of response, 12.6 months first line, 8.4 second line, 9.7 months in the second and even in the third line setting. So impressive duration of response and the progression-free survival I've shown you in the previous slide, 12.3 6.9 and 5.4 in the second and third line. So we are always concerned about the adverse events. And thankfully, the grade 3, 4, I draw your attention to this part of the slide. Grade 3, 4 are just single digit, and it's peripheral edema. Imagine crizotinib gives rise to up to almost about 40% peripheral edema. And this drug is just about under 10%. Nausea, vomiting, which is just a small number of patients. All grades obviously has to be higher, but generally very manageable. And in conclusion, the preliminary efficacy results of the expansion cohort are comparable to those previously treated, reported for the cohort 5B, that is the treatment naive. And in the pre-treated patients, the overall responses are good. There is a meaningful the duration of the overall survival up to about 20.8 months and 13.6 months in the treatment naive patients and in the treatment pre-treated patients. So the message out here is that the drug is active, the sustained responses are seen, quick responses are seen, and the side effect profile is quite manageable. Apart from nausea, vomiting, and the peripheral edema, it is a very well tolerated drug. No major organ specific toxicities have been reported in the earlier cohorts and even in the expansion cohorts. With that, I come to the end of the presentation and would be happy to take questions on that.
Thank you, sir. Thank you for so vividly explaining the MET exon 14 skipping mutation. I think, and these were very impressive results which we have seen with capmatinib. I think this really emphasizes on the need to do a broad gene mutation testing for all lung cancer patients, so we can identify these mutations and we can use these drugs for our patients and have such impressive results of almost disease control rate of 90% in treatment naive patients. So with this, before we move forward, I would just like to, there's a question which was put by Dr. Vikram to Dr. Priya ma'am. In case of brain mets, ma'am, are you there? Could you please take this question? Or Dr. Jyoti ma'am or any of our senior speakers could take this question. It is from Dr. Vikram. In case of brain mets, how do we choose and sequence lorlatinib and RT? Okay.
I think generally there is a paucity of data on the sequencing, number one. And thankfully, lorlatinib is a drug with a very short half-life and less than 24 hours. So you can afford to stop the drug just for a couple of days prior and finish off the radiation, and you could go back to the use of drug within a few days following radiation. Now, the concern generally has been the heightened CNS toxicity traditionally with all these small molecules. And it's generally a good practice to withhold your, the drug for a few days. And as I said, it's a very short half-life. It's a few hours actually.
Thank you, sir. So I think we can. Are there any more questions? We are very much on time, so we can take a couple of questions. Okay, so as we move forward, now that we have discussed the ALK mutation, the ALK rearrangement, the MET, we go a step back to the ROS rearrangement, which we have a drug and also a newer drug which has been recently approved. I invite upon Dr. Rajat Bajaj, consultant medical oncologist at Fortis Hospital, Noida, to please discuss this topic. Thank you.
Hello, Dr. Rajat, can you hear me?
Is Dr. Rajat there?
Hello, Dr. Rajat.
Am I audible?
Your
voice is breaking, Dr. Rajat. Yes, yes. Am I audible?
Yes,
You
sir.
are audible now. Hello. Yes, am I audible?
Yes, you're audible, sir. You may
Yeah,
proceed.
just a minute. Am I audible now?
Yes, sir, you're audible.
Hello. Okay.
Yes, sir, you are audible.
Can somebody share my slides, please?
Yes, yes, I have shared. You can see the screen, sir. Hello, Dr. Rajat, can you hear us? Hello.
Dr. Rajat?
Dr. Rajat, can you hear us?
Yes, I can hear you. Am I audible?
Yes, sir.
Now you are audible. Yeah.
Okay, okay. So I think the problem, so I'll keep my video short. I thank Dr. Vaid sir for having me here. Thank you, Pfizer. The topic that has been given to me is ROS1 rearranged non-small cell lung cancer. What is the treatment in 2022? Next slide. So a little bit about the background of ROS1, as we do know that non-small cell lung cancer has now become the poster boy of precision oncology for the last decade or so. Next slide. With the coming in of a lot of oncogenic driver mutations in non-small cell lung cancer, there has been a sea change in the treatment of NSCLC, and not only has the treatment changed, the expected outcome, the overall survival also has undergone a lot of change, all in the positive sense, with patients living up to 5 years now. This disease was considered almost like a death sentence about 15 to 20 years back. So like we have many oncogenic driver mutations, we have ROS1 rearrangements as one of the oncogenic driver mutations. ROS1 rearrangement is not identified in a lot of metastatic non-small cell lung cancer patients. If we talk about the most common ones, we have EGFR, we have ALK. ROS1 rearrangements only in 1 to 2%, but certainly very important, because if at all we are able to find these rearrangements, we have got important targeted therapies which bring a lot of difference in the quality of life and certainly the duration of survival. ROS1 rearrangements was first found in glioblastoma, and after that found in a lot of cancers, including NSCLC. There are different partners of this ROS1 proto-oncogene, as we can see on the screen, and almost all these rearranged proto-oncogene mutated domains, they get targeted by our targeted therapies which are available. Next slide. So ROS1 is phylogenetically related to ALK. That is why there are many ALK inhibitors, including crizotinib, which have sensitivity for ROS1 inhibition as well. Next slide. If we talk about how it really started, that is targeting the ROS1, this all dates back to 2014, the trial that we are all aware of, which is called the Profile 1001 trial. Next slide, which was published in NEJM in 2014 by Shaw et al. This trial, of course, is a phase 1 study that we all are aware of. And initially, the part 1 was only the dose determining study, after which the part 2 started where crizotinib was used in the dose of 250 milligram twice a day, initially with ALK positive NSCLC cohort patients, but eventually with the preclinical studies indicating the ROS1 positive NSCLC patients also benefiting from crizotinib. There was an expansion cohort which was added in this particular phase 1 study, which took about 50 odd patients of ROS1 rearranged NSCLC patients. Next slide. Like I just mentioned, this is the schema of the expansion cohort of ROS1, which was added in profile 1001. The entry criteria were that the patient had to be a locally advanced, inoperable, metastatic non-small cell lung cancer. Positive for ROS1 rearrangements. Important that at that time ROS1 rearrangements were found out by either RT-PCR or by FISH. A good performance status and treated brain mets were allowed. And in the period of 2010 to 2013, crizotinib was given 250 milligram BD in the standard dose to such patients, with the endpoints being overall response rates and the duration of response, among others. Next slide. So if you look at the baseline characteristics, they were mostly patients who were having adenocarcinomas, which is understandable. Mostly patients who were Caucasians, about 60% of them. Non-smokers, as we will agree, all of us, mostly females, and the median age was about 55 years. So almost the real world setting that we see in ROS1 rearranged patients, this was included in this particular trial. Next slide. So this is the progression-free survival, which was one of the endpoints. And the progression-free survival was a robust PFS at about 20 months, 19.3 months to be exact. As we can see, the Kaplan-Meier curve is almost plateauing after about 45 months, which is a good sight to behold for a medical oncologist. Next slide. And this is the waterfall plot, which very clearly tells us exact as to what nicely are the response rates of this particular therapy, which is crizotinib in the ROS1 rearranged population. If we see the partial responses are about 60%. The complete responses are more than 10%, with the stable disease is about 18%. So the disease control rate of over 80% is what was seen, which is excellent, and always nice to have such disease control rates with a good quality of life in these oncogenic driver mutation patients. Next slide. Even the median time to response is just about 7 to 8 weeks, which is very reassuring for a clinician, so that a patient who does not have a good performance status in the beginning can also be offered these therapies, and one should not really resort to chemotherapy thinking that the responses will be earlier with chemotherapy. 6 to 8 weeks is an acceptable treatment response time. We are always very concerned about the safety data, so the adverse events also were noted, which were kind of similar to what we knew with crizotinib in ALK inhibition. Grade 3 adverse events were about 35%, and there were no treatment related adverse events leading to permanent treatment discontinuation. So the treatment related adverse events were acceptable, and now over a period of time we've been able to understand how to manage these adverse events of fatigue, of difficult color vision, and this muscle aches. All these things, we do know that how to manage all these things. Next slide. So like I said, the vision disorders were there in about 85% patients, but there were no grade 3 such events. The nausea and edema was seen in about 50% patients, but that also was manageable with nearly no grade 3 such adverse events. Diarrhea, vomiting, about 40% patients, again with no grade 3 such events. Next slide. So we had an updated analysis of Profile 1001 in 2019 in Annals of Oncology, with the median OS being in excess of 50 months. Like I said in the beginning, this was something which one could not have imagined in the metastatic NSCLC domain about a decade or a half back. So that is why very important to look for these ROS1 gene rearranged patients, and if at all, we should give crizotinib to such patients. Next slide. Next slide, please. If you look at the various partners of ROS1, almost all of them have responded well to this therapy, with CD74 responding the most, up to about 70 months of response has been seen. Next slide. So to summarize, we in the analysis of profile 1001, especially in the updated analysis in 2019, the median OS has been 51 months, median PFS of about 19.3 months, with overall response rates of 72%. The grade 3 adverse events were manageable, with no new safety signals springing up and causing any concern. The time to treatment response was about 6 to 8 weeks. Next slide. So crizotinib has been approved by US FDA and later by European agencies for the treatment of ROS1 rearranged NSCLC patients in the first line setting. Now we move to lorlatinib. So lorlatinib is not approved in ROS1 positive patients, but short of approval as of now, there is enough data to suggest that lorlatinib also has got an improved efficacy in ROS1 positive patients. So this is what we'll see. Next slide. So we do know that in patients who are previously treated with crizotinib, there is emergence of resistance to crizotinib. In ROS1 patients, that resistance is in the domain of G2032R. Also, in patients who are having ROS1 gene rearrangement, there is higher chance of brain metastasis compared to non-oncogenic driver mutation NSCLCs. So these was the two reasons why we needed some molecule to come up which would act more in the brain as compared to crizotinib. We do know that crizotinib intracranial responses are about 60%, but then can we better them? The answer is probably yes with lorlatinib. Next slide. So the study that we are talking about again is a phase 1 to 2 study, is a single arm study. There are no phase 3 trials as of now, neither with crizotinib nor with lorlatinib. This also in the part 1 was a dose escalation trial from 10 milligrams to 100 milligrams per day. And then coming on to part 2, where 100 milligrams of lorlatinib was given in ROS1 positive patients. Very less number of patients, only 12 at that, but certainly results which were encouraging, and we can expect more number of patients to be included in this trial in the coming future, and more data coming up. Next slide. So this is the schema where again nearly the same eligibility criteria as was there in profile 1001. Different doses have been used across the different centers, but the generally acceptable dose in most of the trials, which most of the centers which have been there in this particular trial, is 100 milligrams per day, with the primary endpoint being overall response rates. Next slide. The baseline characteristics have been nearly the same, most of them adenocarcinomas, females more than males, never smokers, and very important to note that number of patients with brain mets at the baseline was nearly 60% in this particular trial, with previously irradiated patients in the brain being about 50%. And as we can see, lorlatinib has not been used only in the first line, only 1/5 of the patients were given lorlatinib in the first line, and 80% of them, they were all post the various lines, and about 20% of the patients were post at least 3 lines of therapy. Next slide. If you look at the tumor responses, Then we're talking about two subset. One is the TKI naive patients, which was 1/5 of the category, and the other is prior crizotinib only. Only crizotinib being used, that is only one line of therapy. So definitely it is understandable that the responses are going to be better in treatment naive patients. So about 60% responses in treatment naive, whereas 35% in prior crizotinib only. The complete responses were 10% and 5% respectively, with partial responses being 52% versus 30%. So definitely treatment naive patients have responded much more than the prior crizotinib, but the prior crizotinib patients also have responded. So as of now, we do not have any approved drug to target ROS1 beyond crizotinib, but lorlatinib certainly is a robust option that we have as of now. And if you look at the intracranial responses, there also the results are certainly not disappointing. Intracranial responses about 65 to 70% in TKI naive, whereas prior crizotinib is about 40%. Like I said, 60% of the patients in this trial had baseline brain metastasis, out of which 10% were untreated. Next slide. So if you look at the waterfall plot, that also is quite reassuring, almost like what it was for crizotinib, with the responses being uh, uh, in excess of 75 to 80%, and there were about 10% patients achieving a complete response. Next slide. This was for the TKI naive. If you look at this one, this is for patients who had crizotinib as prior use, and crizotinib as prior use. Also, we can see that the waterfall plot is still in favor of the lorlatinib uh, cohort of patients, with intracranial responses also being achieved, and patients having a good extracranial response as well. Next slide. This we've already discussed, that there was an extracranial response as well as an intracranial response. Next slide. Yeah, next slide, please. If you look at the progression-free survival with TKI naive patients, it was, remember, with crizotinib, it was about 19 months cross-trial comparisons, but almost nearly the same PFS with lorlatinib in the first line, and prior crizotinib, it was about 8 to 9 months. Next slide. If you talk about the patients who received one prior non-crizotinib or more than two ROS1 inhibited TKIs, then these patients did not do as well as patients who had to receive crizotinib in the first line. Next slide. But the important thing to understand is that even these patients, they had a improved intracranial responses to the tune of about 20 to 25%. So certainly this drug has got better intracranial responses compared to crizotinib. Uh, the molecular analysis for this trial is still ongoing, where they're trying to find out whether tissue and blood samples which were taken have detected any new mutations in the domain of ROS1 post-Crizalc, and this is an ongoing study as of now. Next slide. Yeah, next slide, please. So lorlatinib has got activities, what was seen in this study, against all the different ROS1 resistance mutations. Only one mutation, which was a glycine arginine mutation, did not respond, but all the other mutations post one line of ROS inhibition responded well to lorlatinib. So lorlatinib certainly is pitching strongly to be the second line therapy at best for the ROS1 rearranged patients post crizotinib. Next slide. Next slide, please. We've discussed that there was a CNS improvement in almost all the patients. Safety signals of lorlatinib is like we already know with the Crown study, the hypercholesterolemia and hypertriglyceridemia with edema and peripheral neuropathy was there. And this is something that we are learning now to manage with lorlatinib. Next slide. And there were not many treatment discontinuations as well, and no treatment-related deaths were reported. Next slide. So to summarize, this molecule lorlatinib has also has shown very good responses both intracranially and extracranially. Almost extracranial responses have been the same for first-line treatment as was with crizotinib. Intracranial responses have been a shade better, but we do understand that cross-trial comparisons are not the right thing to do. Different treatment-related adverse events are there with crizotinib, which we know from the other trials of lorlatinib as well. Apart from crizotinib and lorlatinib, there is another molecule called entrectinib, which has been approved by US FDA in 2019 for the treatment of first-line ROS rearranged NSCLC patients. We don't talk about that molecule that much because it is not available in our country as of now. But the WCLC 2020, there was a good data presented of entrectinib in ROS1 rearranged patients where a pooled analysis of 3 phase 1 trials was presented, which told us that the PFS of this entrectinib is about 20 to 21 months, and the intracranial responses are to the tune of 70 to 75%, with about 15% patients having complete responses intracranially. So entrectinib very much is an important molecule for ROS1 inhibition, ROS1 rearranged patients for ROS1 inhibition. And only we need to see entrectinib seeing the light of the day in Indian market, and certainly it is a force to reckon with in ROS1 rearranged NSCLC patients. So with this, I thank the organizers once again for having me here. Thank you, Dr. Vaid sir, Dr. And Pfizer for having me here, and back to the organizers.
Thank you, Dr. Rajat, for this comprehensive talk. As you mentioned, I think it is the intracranial response rates with lorlatinib which would make it a favorable drug in future, and as a first line for ROS1 mutated non-small cell, ROS1 rearranged non-small cell lung cancer also. We can take up a few questions if there are any. Okay, so I think we move forward. The list of actionable targets in non-small cell lung cancer is still expanding. And these are some of the new targets against which the therapy, there are a lot of research going on, HER2, HER3 and TROP2 in metastatic non-small cell lung cancer. I invite Dr. Sumant Gupta, Sir, Senior Consultant Medical Oncology at Sarvodaya Cancer Institute, Faridabad, for this talk.
Good evening. First of all, I'd like to thank the organizers for giving me this opportunity. Today, I'll be speaking on implications of HER2, HER3, and TROP2 in metastatic NSCLC. As we'll be having a lot of students also in the meeting, and it is a different topic, I'd like to start this topic, which is a very different topic with some baseline working, and then I'll come to the 3 major trials which are on these topics, which are basically, some of these are CCO slides and which have been presented in various meetings, and we'll like to go forward in this schema. So all of us have been accustomed to HER2/neu. So overexpression, amplification, and mutations in HER2/neu has been described in the patients with NSCLC also, as with many tumors, including breast cancers. Therapeutic efficacy of HER2/neu targets, including anti-HER2/neu antibodies, ADCs, and small molecule tyrosine kinase have been tested in the HER2/neu subgroups in the non-small cell lung cancers. Compared with all these 3, the most specific has been the HER2/neu exon 20 mutations, which is the most targetable HER2/neu directed therapies in lung cancer. The other mutation is the HER3. HER3, as we all know, is a member of EGFR family of receptors, and HER3 works as a heterodimeric partner for the EGFR, HER1, ERB2 or the HER2/neu, and the HER4. So just a diagrammatic receptor thing that HER3, HER2, HER4, HER1 The heterodimerization is the only method by which the cascade works, and we need these to start the onslaught of the tumor cells to start the multiplication. So HER3 is the most important for the heterodimerization to start. So coming back, Zhao and Zia, the landmark paper in NSCLC, we have all the major molecules which were used in phase 1 trials. We have pertuzumab, trastuzumab, PDN1. Our newer drugs were studied in various phase 1 studies, and these were analyzed in this paper. Destiny Lung 1. This was a phase 2 trial of trastuzumab deruxtecan in HER2 mutated metastatic NSCLC. As most of us know, 3% of NSCLC will have HER2 mutation. HER2 mutation is associated with younger age, females, never smoker. This is also associated with a poor prognostic subgroup, increased brain metastasis. So TDXD is a HER2 targeted ADC approved for the use of metastatic HER2 positive breast cancer and gastric cancers. And Destiny Lung 01 study was a phase 2 trial where this was used for a NSCLC relapsed or refractory to the standard treatment. This was the initial Destiny Lung 1 trial study design where it was used in 2 subgroups. One was the HER2 expressing subgroup and the second was the HER2 mutated subgroup. So it was an open label multi-cohort phase 2 trial. The data cutoff was taken in May 2021. Patients were randomized with unresectable metastatic non-squamous cell NSCLC, which were, as I said, in HER2 expressing and HER2 mutated subgroup. These were basically those patients which were ECOG PS 0 and 1 and refractory to the previous lines of therapy, but never exposed to a HER2 receptor subgroup. Primary endpoints were ORR and the secondary were DOR, PFS, overall survivor, DSR, and safety analysis was done. But very soon, the subgroup which was only used or the only analyzed in the further subgroups were the HER2 mutated subgroup. The dose was standard 6.4 milligram per kg body weight, and it was given once in 21 days. So this is the interim analysis which was presented in 202 virtual ASCO meeting between May 29 and 31 in 2020. So this is again the schema. So these are the 42 patients which were taken. The median age was 63, age was less than 65. There was a definite female preponderance. Asians, North Americans, Europeans was quite equally distributed. ECOG performance status was PS01 in most of the thing. HER2 mutation was kinase domain in 90%, extracellular in 4.8. Characteristic-wise, CNS mutations was quite high in 45%, as we'll expect in a non-small cell subgroup. Median lines was 1 to 6 with a, the previous treatment lines was 1 to 6 with a median previous lines of around 2. And these are the lines. Some had got platinum-based treatments, some had got immunotherapy, and some had got docetaxel. So most of the patients had got a platinum-based around 90%, and 55% had got a PD-1 or a PD-L1 based previous lines of treatment. If we go to the response, confirmed ORR by the independent review committee was around 26%. 61%, and that is 26% or 62% to be exact. CRR was seen in 1%, PR 25%, SD in 12%. These are the HER2 mutated NSCLC subgroup, and this is the best change in tumor size as per the ICR. If you see the median, around 25% patient had shown a tumor response. These are the response over time. These are the PFS and the OS curves. The central line is showing the OS probability, and the PS median PFS was around 14, and the OS has not yet reached. So these are the AEs. So the most common AE, the lighter color is grade 1 or 2 reaction, and the darker color is more than grade 3 reaction, which will come in detailed discussion later on. Nausea, alopecia, anemia is the most common one. Anemia grade 3 and 4 was quite common, and neutrophil count decrease was again grade 3 was quite common. Rest of the side effects were mild only. One of the most interesting was lung infection, which was quite different, which I'll come in detail discussion. So if you come to the patient disposition and safety, 5 deaths were associated with treatment, but none of them were deemed related to treatment after the investigations. There was 1 seizure, delirium, fungal pneumonia, but most of the treatment-related adverse events were controlled with dose de-escalations. So none of the treatment-related outcomes were not manageable by dose discontinuation or dose reductions. And when the individual committees reviewed the thing, none of the fatalities, that is the 5 fatalities which happened in the 42 patients, none of them were directly treatment related. The most important AE or the AE of special interest which came out was ILD. ILD occurred in 5 patients. All of them were grade 2 and 1 case of ILD was still pending injection. So out of these 4 which were evaluated, all of them, the drug withdrawn was done. 2 recovered before the data cutoff was done. 1 recovered with sequelae and 1 patient still recovered. 1 has not recovered and this patient is still in a pending form and the drug investigation is going on. All the 5 patients had received steroids for the ILD management. So for the conclusion till now, responses were durable. Median PFS was 14 months. There was no new safety signals observed. Most common AE were GI and hematological. 26% patients had neutrophil count decrease. ILD was a challenging thing which happened in 5 patients, although all were grade 2 as per the committees. 1 patient still, the cause is still to be ascertained. Investigators concluded that the data supported the potential use of this drug to treat patients with HER2 mutated NSCLCs, and the enrollment has been increased to 50 patients for a phase 3 study. The second study which I'll be presenting in the HER2-HER3 group will be a phase 2 study of Poziotinib, an investigational TKI. This has been done in a heavily pretreated EGFR or HER2 exon 20 mutated NSCLC. So most of the phase 1 and the preclinical studies has clearly showed that exon 20 has been the most important subgroup of NSCLC which has shown benefit of HER2 directed therapies. So this is again a small study which showed that Poziotinib, a potent investigational TKI selectively targeting these mutations, should be a very beneficial drug. So this study was used in EGFR or HER2 exon 20 mutated NSCLC. More than 1 prior systemic therapy, stable brain met patients were allowed. 63 patients were taken in the study. Primary endpoints were ORR by RECIST 1.1 and the secondary endpoints were progression-free survival, overall survival, DCR and DOR along with safety analysis. A 16 mg dose of Poziotinib per day, QD, and a treatment continued in 28-day cycle as per the investigators' discretion was used. So this was the cohort of the patient, the EGFR cohort and the HER2 positive cohort. This was again a very well-balanced cohort. Around 28 and 31% had stable brain mets. The exon 20 were mostly insertions, although in the EGFR patients had point mutations. Prior systemic therapies were up to more than 4 lines also. Platinums, TKI, and PD-L1 all were allowed. So overall response rates were in the EGFR around 55%, in the HER2 around 50%. There were no CRs. The partial responses were around 50%. If we come to side effects were quite overwhelming. Patients had very severe, I will personally say very severe, although the investigators did not agree to that. Diarrhea, oral mucositis, paronychia, as we see with all TKIs. If we see the side effects, grade 3, grade 4 side effects were around 50%. Treatment-related side effects as per the ICRs were around 35%. Grade 5 AEI treatment-related was 1. Dose-related de-escalations were done in around 38%. And discontinuation was done in 2% patients. Coming to the conclusions of this study, Positinib exhibited promising anti-tumor activity in very heavily pretreated patients with exon 20 mutations. In the EGFR cohort, the overall response rates was around 55% with a median PFS of 5.5 months. In the HER2 cohort, the ORR was around 50% with a similar PFS of around 5 months. Although the team said the manageable toxicity profile was 60% patients requiring dose reductions, it is quite a significant toxicity burden. But let's see, maybe once the drug comes to a real world analysis, the dose reductions and the newer dosing might decrease these things. The discontinuations due to adverse events was only 3% as per the team. Coming to the third part of my talk is the TROP-T in NSCLC. Human trophoblastic cell surface antigen 2 or TROP-T is a transmembrane glycoprotein that is highly expressed in several epithelial tumors, including NSCLC. And antibody drug conjugates or ADC targeting TROP-T yielded durable response in about a fourth of patients in heavily pretreated NSCLC. If we come to see the diagrammatic schema, TROP-T basically increasing proliferation and decreasing the inhibition of apoptosis via the BCL2 pathway and the Ki67 pathways. This is a small diagram which represents the same. Again, this was in the IASLC 2021 in September 8 to 14, 2021 in the virtual meeting on lung cancer, that a phase 1 TROPION trial, which was a TROPION pan-tumor 1 study, the updated analysis of the drug daptomab deruxtecan, which is a TROP2 directed ADC, was presented in the pretreated advanced NSCLC cohort. As I said, this drug is a ADC, works on the humanized anti-TROP2. It is a IgG1 map linked to the topoisomerase 1 inhibitor via stable tetrapeptide-based cleavage linker. TROPION pan-tumor 1 was the first in human phase 1 dose escalation, dose expansion study evaluating this drug in patients with advanced NSCLC and other tumor types. So in this drug was given in 0.27 milligram per kg to varying drugs. The 3 drugs doses were 4, 6 mg and 8 mg at 21 days interval. Various cohorts of 50, 50 and 80 patients was used in heavily pretreated patients. These are the matched subtypes of patients. This was basically done in US and Japan region. Both squamous and non-squamous histopathology was used. Prior immunotherapy, platinum and TKI groups were used. EGFR mutant population was also used. And around 40% patients in the datopotamab subgroup had history of brain mets. So this is again the ongoing study. PD progressive disease was seen in around 41% of patients. Adverse effects, deaths were not much. And the median duration of study is around a year. So out of the safety thing, the drug was quite well tolerated. Most of the side effects were less than grade 2. ILD was again a side effect which was seen in this drug also. This is the anti-tumor activity. There was no major CRs except for one in this 8 milligram group. Most of the patients had a stable disease. This is the waterfall. So in the conclusion, it was said that in this updated analysis of the ongoing phase 1 TROP-T pan-tumor trial, the overall range from 24 to 28% across the doses. 6 milligram per kg was supposed to be the ideal dose, and it will be continued in the further trial. And we will be escalating this to a phase 3 trial of the TROPION Lung 1 study. So these are the further trials of this drug in which it will be done with other combinations. There is a trial where it is planned with other immunotherapy combinations with Pembro, with Durva, and we might have some interesting results with this drug, which might come in further studies. Thank you. And I once again thank the organizers for giving me this opportunity, and have a nice evening.
I thank Dr. Sumant Gupta, sir, for this enlightening talk on the newer targets in lung cancer. So we have so much happening in the targeted therapy in lung cancer. I think this all emphasizes again the need to offer our patients next generation sequencing so that a broad gene mutation testing can be done for all patients. That would help us identify and offer our patients the best treatment, and also it would help in further research. I think we also need to mention briefly about the liquid biopsy, which is now upcoming, the plasma first approach, which is being discussed. Maybe we can have a small discussion on it during the panel discussion. Moving forward, let's discuss the lung cancers which do not carry any of these targeted gene mutations. I invite Dr. Manish Singhal, sir, Senior Consultant Medical Oncologist at Apollo Hospital, Delhi, for discussion on angiogenesis inhibitor and immuno-oncology based regimen changing paradigms in non-small cell lung cancer.
Sir, can you see the slide, Dr. Manish? You need to unmute, sir. Sir, you need to unmute yourself.
Yeah, so I'll not share from myself, my side. Thank you, Dr. Sheena. And so I'll be discussing about the role of angiogenesis inhibitors and how can we combine them with the ever-increasing platform of immuno-oncology-based treatment in non-small cell lung cancer. So next slide, please. Next slide. So many of our ardent efforts to find a drug as far as angiogenesis inhibitors are concerned, they fell out of vogue because most of the initial trials were negative. And as you can see over here, that many drugs such as motisanib, sediranib, and many such drugs. Just knock it off. Yeah. So many such drugs were not considered helpful, and so many initial attempts failed. Next slide. The first successful drug was the ECOG 4599, and this was in combination with in the background of paclitaxel carboplatin. We showed that the median progression-free survival improved. So was the overall survival, and for the first time in the history of non-small cell lung cancer, non-squamous variety, the median overall survival crossed the 12-month mark, and it was 12.3 months in the experimental arm. Similar studies with a lesser dose of bevacizumab showed that the benefit was lesser, and it didn't really touch the significant hazard ratio in terms of median overall survival. However, then there were several other studies which did not really randomize between bevacizumab or no bevacizumab. They were mainly randomization between users of pemetrexed in the background of bevacizumab or not. Next slide. So these were various studies. One was the ECOG 5508. One was a West Japan Oncology Group study, which randomized patients to paclitaxel carboplatin bevacizumab followed by a switch maintenance to pemetrexed, or continuation of bevacizumab or continuation of bevacizumab and pemetrexed, trying to answer the question that how does bevacizumab plus pemetrexed actually fare against pemetrexed alone, or for that matter, bevacizumab alone. Going to the next slide. So many of these studies did show that the progression-free survival improved with addition of bevacizumab plus pemetrexed as compared to pemetrexed or bevacizumab alone. So perhaps only bevacizumab is also giving us a good progression-free survival in comparison to pemetrexed alone. But if you combine the two, there is even further increase in median progression-free survival. This did not really result into a significant improvement in overall survival, though. But many a times, a combination of bevacizumab and pemetrexed is used in treatment of non-small cell lung cancers. Next slide, please. So if you look at the various trials, what about how to use a maintenance therapy after treatment for a non-small cell lung cancer? So one has the option of using cisplatin pemetrexed and then going on to pemetrexed maintenance alone. One has the option of using bevacizumab, so that definitely increases the progression-free survival, not the overall survival, in a statistically significant manner. And one is going for a paclitaxel carboplatin bevacizumab, then switching the maintenance to pembrolizumab bevacizumab, which gives you around 7.5 months of progression-free survival, which is not really leading on to a increase in median overall survival. So various ways of looking at it. Perhaps the jury is still out that what's the best way. But whatever evidence we have, I think the most cost-effective way is cisplatin pemetrexed followed by pemetrexed maintenance, not really bringing in bevacizumab to increase only mere progression-free survival, unless until somebody has a really profligate budget to treat their disease. Next slide, please. So there was an ardent interest in how VEGF inhibitors can be combined with immunotherapeutic agents, and there was a good amount of interplay, and it was seen that the abnormal vasculature, which is corrected by the use of VEGF inhibitors, can cause more T effector cell infiltration and also cause upregulation of PD-L1, and the hypoxia induced because if there are distorted vasculature, there's relative hypoxia, which decreases immune cells to go into the tumor microenvironment. So overall have immunosuppressive effects. So a combination of VEGF inhibition and immunotherapeutic agents was decided. So if you see these, there is definitely some strategies wherein VEGF inhibition can be combined with immunotherapeutic agents to enhance their each other's effect. Next slide. Next slide, please. So we all understand the IMpower 150 protocol, and it was a randomization in the background of paclitaxel carboplatin bevacizumab, the ECOG 4599 protocol, and adding atezolizumab to it, and then maintaining with atezolizumab and bevacizumab. And the primary endpoint of this particular study was median progression-free survival, as also overall survival in the intention to treat population. Next slide. So the study met its primary endpoint, and the intention to treat population did improve from 6.8 months to 8.3 months, which was statistically significant. Next slide. With a hazard ratio of 0.62. And so was the overall survival, which was improved with a hazard ratio of 0.78. And the US FDA granted its approval for the use of bevacizumab and atezolizumab in the background of paclitaxel carboplatin. Next slide. So this was true for all comers, not only the PD-L1 high population, the PD-L1 low, as well as the PD-L1 negative population harbored benefit from the combination of bevacizumab and atezolizumab in the background of paclitaxel carboplatin. Next slide. There was a subgroup analysis, which was a pre-planned subgroup analysis, which was liver metastasis, and they did find that those patients who had liver metastasis actually fared even better and had a more impressive hazard ratio as compared to those who did not have a liver metastasis. So the hazard ratio was 0.52 for those patients who had liver metastasis and were treated with an ABCP combination. Next slide. So there is a lot of role of VEGF pathway inhibition in second line, and I think this is the major area where we exploit this pathway in the treatment of non-small cell lung cancer. Next slide. Again, the initial attempts were negative, but we had some positive studies in the second line, in later lines. Next slide, please. So the two positive studies were nintedanib and docetaxel one, and the other one was ramucirumab and docetaxel. Next slide. So there were two studies, the REVEL and the LUM lung study. Although the interest in nintedanib fell off because there was some other studies which came out to be negative. Only the LUM lung study was positive. The other studies came out to be negative, but definitely REVEL study was a positive study, which looked at not only squamous cell histology, but also non-squamous cell histology as well as squamous cell histology in terms of progression-free survival and overall response rates and disease control rates. Next slide. So if you look at the primary endpoint of this study, the median overall survival was met. It was 10.5 months versus 9.1 months. And so was the median progression-free survival, which was also met. And there was a 1.5 months improvement in the median progression-free survival with the addition of ramucirumab to docetaxel. Next slide. Similarly, in the LUM lung study, there was improvement in progression-free survival as also the improvement in median overall survival. Next slide. So the major problem which came with nintedanib was grade 3 diarrhea and liver enzyme increase. But I think because of the increased toxicity, nintedanib fell off from as a preferred agent to be combined with docetaxel. Next slide. So if you look at the entire data set of docetaxel, ramucirumab, docetaxel, nintedanib versus what we can achieve with either nivolumab or pembrolizumab, so we know that the median progression-free survival is about in the range of 4.5 months to 3 months, and this is where we are. And the median overall survival hovers around a year, 9 months to 12 months. So this is achievable by all means. Either we use nintedanib plus docetaxel or ramucirumab, or a matter of fact, we use either of these immunotherapeutic agents, such as the nivolumab or the pembrolizumab or atezolizumab coming from the OAK trial. So the median overall survival hovers around a year in the second line. Next slide. So certainly VEGF inhibition is something which can be used. There was one curious thing in the LUM lung study. We showed that those patients, and also from the REVEL study, that those who are early progressors and who tend to progress within 9 months, they tend to do better when a VEGF inhibition is brought in, either in the form of nintedanib or in the form of ramucirumab. So these patients tend to progress faster if they have very short time on their first line therapy, and they are the patients who perhaps benefit the most from the addition of a VEGF inhibition. Next slide. Such patients are not likely to do well even with immunotherapy. That is what we have learned. So these are the various guidelines, and they are in keeping with their respective clinical trials. So all of these options are vindicated by the respective clinical trials, and so it is. I think we all understand them very well. Next slide. So there's also role of VEGF pathway inhibition in EGFR mutant advanced non-small cell lung cancer. Next slide again. So there is a rationale that the blockage of VEGF inhibition can actually enhance the anti-tumor effect of EGFR TKIs, but this is mainly in the background of erlotinib. There has been 2 randomized controlled trials which were published in this very ISMO meeting to 2021, wherein bevacizumab or a VEGF inhibition was combined in the background of osimertinib, and both the clinical trials actually did not show any improvement in progression-free survival or overall survival in the background of osimertinib. But yes, in the background of erlotinib, there was improvement. Next slide. Which makes me believe that that perhaps there is an interplay between the drug and the VEGF inhibitor, and it is drug specific and not really specific to only EGFR TKI inhibition. So various studies have been done, and the NEJ026 was a randomized controlled trial which did show that the median progression-free survival improved, but this did not lead on to an overall survival improvement which was statistically significant. Next slide. The RELAY study is an approved study because that randomized patients to erlotinib versus erlotinib plus ramucirumab, and it did show that the median progression-free survival was improved. It improved from almost 12 months to almost 19 months, which is the ballpark figure for osimertinib median progression-free survival in an unselected patient population with either EGFR or EGFR L858R or exon 19 mutation. Next slide. So there was definite improvement in median progression-free survival. There was good tolerance of the protocol, and not many side effects which are unexpected were there. Next slide. And as I said, that it crossed the 19 months mark, which is the ballpark figure for osimertinib. So certainly ramucirumab and erlotinib is one possible combination which can be used. And there is definitely some interplay as far as erlotinib is concerned. This doesn't hold well with osimertinib though. If you look at the 2 EGFR mutation, either exon 19 or exon 21, both have significant improvement in median progression-free survival, which is very much alike and the time estimates, the point estimates are much overlapping between these two mutations. Next slide, please. So even as time passes by, and even as, so there remains a distinction between those patients who are receiving ramucirumab and erlotinib. So definitely there is the rates of EGFR T790M mutations remain lower with the addition of ramucirumab and erlotinib. So there is definitely better disease control which lasts with ramucirumab erlotinib. Next slide. So a very consistent response rate of around 75%, progression-free survival reaching almost 19 months with the addition of VEGF inhibition. Next slide. So if you look at the median progression-free survival, I think 19 months, 18 months is the ballpark figure which should be achievable by addition of either a VEGF inhibition or using osimertinib, or even using a combination of chemotherapy and a EGFR TKI. Next slide. So just to show that FDA did approve atezolizumab in combination with bevacizumab for first-line non-small cell lung cancer and non-squamous type with no EGFR and ALK genomic mutations. Next slide. Next slide, please. So unfortunately, we don't have any predictive prognostic factors to decide on which is the best patient to where anti-angiogenic therapies can be used. And the only marker is the patient should be a non-squamous non-small cell lung cancer, or a patient with EGFR mutation wherein you are contemplating to use erlotinib. Next slide. So there are various forms of resistance which happens with anti-angiogenic therapies, but it is, I think it is quite complex, and we don't really know how to deal with the resistance to anti-angiogenic therapies. But yes, there is interplay of a lot of downstream signaling pathways which may lead to resistance. And therefore, there is role of continuing the VEGF inhibitor even beyond progression in many cancers. Next slide, please. Next slide. So I think this is my last slide. So there is definitely some optimism because of the use of VEGF inhibitors in the treatment of non-small cell lung cancers. But the treatment of non-small cell lung cancer is really expanding very fast. And with the advent of immunotherapy, I think it becomes difficult to decide which one to use and which immunotherapy and which one to combine with anti-angiogenic therapy. It would be wonderful to see if anti-angiogenic therapies can be combined with other immunotherapeutic drugs such as pembrolizumab or nivolumab, but we need to wait till that type of data comes up. With that, thank you, and over to the organizers.
Thank you, sir, for this comprehensive talk. I think, as you mentioned, the theoretical basis of combining the angiogenic inhibitors and the checkpoint inhibitors, we may have many more trials on this, and I think we may have many more approvals of this combination regimen. With this, coming to the last session for today, we have a panel on uncommon mutations and sequencing in lung cancer. I call upon Dr. Nagendra Sharma, sir, consultant medical oncology at Medanta Cancer Institute, for taking forward this discussion with our esteemed faculty.
Thank you very much, Dr. Shaina, for giving me the opportunity. And I want to thank at the outset Dr. Vaid sir and the sponsors for giving me the platform to take us through on this uncommon mutations and sequencing. So I will be presenting one case which I have treated, our team have treated nearly 4.5 years back, and how this case have unfolded, it is amazing. So I will be sharing my experience, and I will be taking inputs from all the panelists and my teachers. So I'll be coming to the presentation directly. Right. So at presentation, 42-year-old female patient with comorbidities of hypothyroidism and migraine, with no significant family history of malignancy in any of the family members, first degree or second relative. Initially, patient was evaluated elsewhere and later at our institute. And the presentation was the patient was presented with the generalized tonic-clonic seizure on and off for past 7 days. Initially, patient was evaluated by neurology team neurologist upfront advised contrast mass MRI of brain in March 2017. That is nearly 4.5, 5 years back. Multiple suspicious metastatic lesions were there in bilateral cerebral hemisphere and right thalamus and right cerebellum. The largest one was in the left parietal lobe. The dimensions were 2.7 into 2.5 centimeter. So the medical oncologist was called, and I was the medical oncologist on duty that day, and immediately I advised a FDG PET scan, whole body contrast, and the PET scanner picked up that the patient was having a right lung mass in the upper lobe. The dimension of that was 5.5 cross 5 centimeters, suggestive of primary mitotic etiology, and patient was also having FDG-avid brain lesions, bilateral pulmonary nodules, and mediastinal and right hilar lymph nodes, suggestive of a metastatic disease. So this was in 2017. So the oncological principles were followed, and the right lung biopsy was performed by the interventional radiologist, and it was reported as NSCLC favoring adenocarcinoma. Immunohistochemistry, TTF1 was positive, and P40 was negative. So it is a straightforward case, no doubt about that. And the patient's performance status was reasonably good. It was performance status 1. So my question to the panelist, my first question to Dr. Manish sir. So in 2017 and 2022, so what will be your molecular testing in 2017? And what all biomarkers do you send for, or in what sequence? And second question is, do you order NGS or wish to order NGS or comprehensive genomic profiling like fMRI or other platforms testing upfront routinely in your clinical practice in 2022 right now? So what is your take, sir? I think Dr. Manish sir is there.
So Dr. Manish has logged out due to other meeting. Hello.
Right. So
Dr. Vaid is also here.
Okay. Okay. May I ask Dr. Vaid sir, how our practice have changed in last 5 years? Because so much new things are there. There's an explosion of positive trials. There are so many mutations. There are so many actionable drugs are there. So how you are treating your patients now, and how your practice has changed in the last 5 years?
So I wouldn't say that the practice has changed. I think our access, and our understanding has changed. In 2017, we were wishing that we have something more than what we were doing at that point in time. And we would do more in a sequential manner. Send an EGFR, go by the law of probability. And as we say, the proverbial, that a lot of water has flown under the bridge. And similarly, a lot of water has flown in the Yamuna since then, in the last 5 years. So we have come to a point where the access to the next generation sequencing has become easier, it's become quicker, the turnaround time is quicker. Imagine 2017, nobody would talk less than 3 weeks. Today you have the NGS in-house, and you would get the report in 5 to 7 days time, and sometimes even earlier. So I think our access, our ability to process the tissues has changed. You would want to do an NGS, but I wouldn't agree with the type of the comprehensive genomic profiling. For what? We have only 4 or 5 or 6, half a dozen actionable mutations at this point in time. It's like unraveling, too much and getting information which is not actionable, and the cost factor as well. Let's not forget these drugs itself, they come expensive. The tests also are expensive, and we are adding the burden of testing onto the patients and families. I would be happy to still look at my patient, look at the finances, optimize the finances. And there is no one solution. There is no one size which fits everyone. NGS or CGP is not for everyone. We still may do an EGFR ALK immediately, do a MET and a ROS1. And if everything is available, the finances are available, do an NGS. Comprehensive genomic profiling is a big no from my side. And I don't do it. I have never done it for a lung cancer de novo right at the time of diagnosis.
Absolutely right, sir. Perfect answer. No doubt about that, sir. What you are told is there's a lot of factors which factor into our decision making, what type of molecular testing we can do. So right now we are dealing with this scenario all the time whenever we are seeing a patient upfront. So these are the questions which hovers around or tickles us, and we have to think on the back of our mind, what should be the ideal workup, whether we should go for a minimal workup, we should go for a comprehensive large gene panel or a small gene panel. And right now we are having a lot of coupon testing also available in our hand, like Novartis coupon, 8,500 rupees. We can do all these things. There are merits and demerits to each one of these. So, what is your take? Like, what are the factors which will decide that I'll be going for ideal work? Obviously, cost is a major factor which decide, and accessibility and affordability is always there. But what are things like, even if you want to do a limited gene panel, what will be your biomarker selection?
So who's taking that question? Dr. Jyoti?
Dr. Jyoti ma'am is there, sir?
So even Dr. Jyoti and Dr. Priya Tiwari is also not there.
Okay.
Dr. Rajat or Dr. Suman?
Dr. Rajat is about to join. Dr. Sumant will not join, sir. So Dr. Rajat is about to join next few minutes.
Maybe Dr. Shaina can take it. She's
right.
done a wonderful job on this evening.
Thank you, sir. Yes, so I think, sir, I would also go with what sir said. However, one point I would like to add, sir, that if we do a NGS or a comprehensive genomic panel is what we were talking about, I think only from the research point of view, we may have a good database of our patients. Like most of the data that we have is from the Western countries. So looking at it from that point of view, the patients who can afford it, I would like to offer and maybe build up a data which can be used later for research. So here, the ideal workup is, like we discussed, in the lung gene panel in the NGS, what I would like would be EGFR, ALK, ROS, then ROS1, MET, exon 14, MET skipping mutation, and then the PDL1. The other KRAS, RET, we do not have the targeted therapy available in India, so maybe we can keep it for later.
Perfect. No doubt what you're told is absolutely right. In oncology, the basic dictum is that if you think of common things first, we will be commonly correct. And if we think of uncommon things first, we will be uncommonly correct, isn't it? So ideally, we have to take multiple factors into account, not only the cost, the availability of the clinical trials are there or that or not. But second question is, like, if you want to do a PDL1, you mentioned PDL1 also to be done as far as decision making is concerned. Suppose the patient is not affordable. And is there any point in doing PDL1 then? Because you are knowing that the patient is not going to afford immunotherapy per se. So I'll be using targetable drugs if at all that actionable mutation is available. But are you doing PDL1 in all the patients, or you're selective in your approach?
So point taken, but I think usually we do it. But yes, point taken. We should first look into the targeted mutations, and then maybe if finances allow, then do the PDL1.
Right. But even if I will tell that even if the finances won't allow, PDL1 have to be done. Reason being, sometimes we are having the option of putting the patient into clinical trial. So if PDL1 is done and if patient can get the drug for free, why not to use that? So always that have to be done, no doubt about that. So even if like PDL1 is to be done, so whether your choice of platform depends upon the immunotherapy drug which you are planning, you will be in consensus with your pathologist that use this platform for doing PDL1 in this testing, or you are stuck if you are done coupon testing, there are only 2 platforms available, right? So how you're taking that forward?
Nagendra, the panels should be clinician-led. The clinicians should sit with the pathologists and discuss the availability of drugs, the possibility of usage of each one of them, and they should be customized, they should be individualized. That's what I believe. And as far as the ideal workup is concerned, we are not practicing in an ideal scenario. So there is no ideal workup actually. I don't believe that there is an ideal workup. The workup is as suits for an individual patient. Coupons are good, they're not bad. At least they give you access to at least 5-7 markers. So I think every department has to sit down with the pathology department, make a lung panel, And at least that should incorporate those 5-7 markers, which are mandatory to be done because the drugs are available. Anything beyond that is actually a matter of discussion, a matter of debate, whether we should be doing it or we should not be doing it.
Perfect. Perfect, sir. Well said, sir. Coming to the second question, like we are knowing that lung cancer, especially small cell lung cancer, yes, we have to do contrast enhanced MRI brain upfront because there are 10 to 15% chances that we can miss asymptomatic brain mets. So my question to Dr. Shaina is like, Dr. Shaina, like whether you are doing MRI contrast brain as a default in all the patients of NSCLC, or is there any stage onwards you will do, or it depends on clinical situation. Like if the patient you are done PET scan upfront and brain, there is no lesion in that, and patient also is asymptomatic, so you can get away without doing any brain imaging. So what is your take on brain imaging as far as NSCLC is concerned?
So in our practice, we are doing the contrast enhanced MRI brain for all patients after stage 2 onwards, usually. Stage 3, stage 4, all patients.
Okay. So actually the guideline says that anybody above stage 1C requires a contrast enhanced MRI brain. But sometimes what happens is MRI brain is not practically possible. Suppose the patient comes to emergency department and is in a poor performance status, directly lands up in ICU and connected to ventilator support. In that scenario, you cannot do MRI brain. So I will be happy to do brain imaging in form of non-contrast CT scan of the brain and take action accordingly. Over a period, most important thing is that brain imaging have to be done. Anything above stage 1C requires brain imaging and have to be done in the clinical setting. So now coming to the NGS part, like as far as co-occurring mutation is concerned, like more and more doctors are planning to do NGS. They are more inclined towards NGS or comprehensive genomic profiling upfront if they are not working in a resource limited setting. So now we are facing one more dilemma, that how to manage co-occurring mutations. There are isolated cases, all of us must have seen, like EGFR is occurring with ALK mutation. There are isolated case reports. And where are we right now? So in a dual mutation positive patients, so Dr. Shaina, what is your take? How will you take your decision if you're using coupon testing or if you're using comprehensive genomic profiling?
So I was hoping to have this discussion, and with all the faculty members, I don't have much experience on that. I think I'm not sure, sir. I think I was.
No, sure. It's an honest answer. No doubt. It's a tough answer question. No doubt about that. And science is unfolding in this era. So what I will answer, like I will put light upon this is, like if you've done a comprehensive genomic profiling, suppose Foundation One or any other platform, there is something known as mutant allele frequency. If the mutant allele frequency is higher for one particular mutation, actually that is a driver mutation. There are drugs which are available for co-occurring mutation, like if you are having EGFR mutation along with ALK mutation, brigatinib is a drug which can be used because it's having dual activity. But sometimes if you are having an uncommon scenario in which two mutations are running together, the mutant allele frequency, which is given in comprehensive genomic profile, that will throw light that what targeted treatment you should use. And I will be open if at all Vatsar also wants to put any inputs in this type of scenario.
Whatever sequencing you do, you would pick up those co-occurring mutations. And then if it is a question of which is the dominant, then it could be kicked up to the next level. But to do comprehensive genomic profiling for 100 out of 100 patients, imagine the amount of money you are going to spend. And how, right. What is the frequency of co-occurring mutations? Let's first answer that question. It's not a common clinical problem. It's a problem solving at a next level. So if right. in your 20 gene or a 50 gene or a 60 gene panel, if there are co-occurring mutations, you could always move up. I don't think the comprehensive gene profiling would be the answer to every patient. You would be, imagine a comprehensive genomic profiling is worth about 2.5-3 lakhs. It's $4,000 US, so which is 3 lakhs of rupees for every patient to begin with as a testing. It's a very scary situation then. Rather than going for 5-7 of those actionable mutations in a lung panel, which is designed and designated by the treating department in conjunction with the pathology department, I think that should be the best way to go about. There is a problem, there is a situation, pick it up, go to the next level.
Perfect answer, sir. Absolutely right, because they are rare mutations. We should not dig for these mutations. We should think on the clinical context, whether we should go for fragmentary test upfront or whether we should go for comprehensive profiling. In the correct clinical settings, we should take there's no straightforward yes or no answer to this. Absolutely right. So right now the pie chart of EGFR mutation or the lung panel is increasing, like EGFR sensitizing mutations are there, T790 mutation, all decision we had, our speakers have covered that diligently in the previous sessions. I'll be using that why precision medicine is needed for comprehensive lung cancer treatment right now. Obviously, we can identify actionable mutations with available and approved targeted treatments. We can identify other non-actionable driver mutations for clinical trials like RET, NTRK, MET, which are uncommon FGFR fusions. It is used for identifying the novel activating mutations in lung cancer and other tumor types like KDD, that is kinase domain duplication, and HER2 TDM1, and identify the resistance mechanism, which happens over a period of time when we are using the drugs in sequence, and identify the novel biomarker for immunotherapy. The TMB also, that also will throw light in next couple of years. Also, there's a lot of debate is going on TNB also. So there are advantages and disadvantages of doing comprehensive genomic profile, as Vaid sir have clearly told. But one thing I want to tell you that there are 17% of false negative EGFR exon 90 alteration missed by a standard testing if you are not doing comprehensive genomic profiling upfront. So there are cases, I'm also having my own experience in which we have done EGFR through RT-PCR, but it was negative. And when we had done it through NGS or comprehensive genomic profiling, it was positive. So we can miss many of patients. That answer is like 17% of patients can be missed if we are not using the correct sequence. This is what the slide is depicting. But coming back to this question, this patient. So this patient, we have done fragmented test, and EGFR RT-PCR have picked up that patient is having an exon 19 deletion, which is positive of it. Other markers in 2017, we have sent ALK by IHC, which was negative, ROS-FISH was negative, and PDL1, DACO22C3 platform was also 0%. So obviously the diagnosis was established that it's a metastatic NSCLC adenocarcinoma. 7th AJCC at that point of it was stage 4 M1B because of multiple brain lesions and bilateral pulmonary nodules. And right now we are using 8th AJCC stage 4B M1C, in which right now I just want to throw light that there's no M1C in 7th AJCC and there is no stage 4C in 8th AJCC as far as diagnosis is concerned. So that time the decision was taken in multidisciplinary tumor board. Our radiation oncology colleague, the patient was symptomatic for brain lesions. So radiation therapy was started in March 2017 as BRT was given to the brain lesions, 35 gray in 5 fractions. In March 2017, patient completed that. Post that, because the reports were ready by the time, and we started this patient on erlotinib. Now we can debate that why you have not started osimertinib or other TKI, but this patient was nearly 5 years back. That time erlotinib also was having a decent brain presentation. So this drug was chosen and started on first generation TKI, and patient have done well. Patient have taken this drug for 8 months, and after that patient have progressed systemically. PET scan have shown a progressive disease, not only in the brain lesions and other sites also. So osimertinib data came little bit later, it was published in a reputed journal like NEJM in January 11, 2018. So that's why we have chosen the drug. So now the patient have progressed on first generation TKI. So what will be your next step? So what you are going to do? Dr. Shaina, can I ask this question?
Yes.
How you will move forward?
Yeah. So, sir, I would prefer to do a biopsy at this point, if possible, solid tissue biopsy. Otherwise, liquid biopsy is also a good option. Liquid biopsy to check for T790M mutation.
Right. Okay. So same thing was done. You're absolutely right in your approach, and we have done for a liquid biopsy, and this patient was found to be having a T790 mutation. So 22 copies in per ml of plasma in the cell-free DNA in submitted sample. And what will be your take? Now, if the patient is having T790 mutation, we all know what is to be done post first line progression. So we started this patient on osimertinib. The FLORA data, we know the median PFS of 18.9 months. Median overall survival is 38.6 months. So overall survival is 38.6 months. So in December 2017, the patient was started on osimertinib, a standard dose of 80 milligram. And patient have done well. Serial scans are showing a response. Patient completed 18 months on osimertinib. Tolerance was excellent, except grade 2 rashes and grade 1 diarrhea, which was managed conservatively. Now what? This is the interim scans in between. And you can see the lesion which was there up front vanished radiologically. So we have done a tissue diagnosis from the progressive side. We had done a right hilar FNACL cell block, and it was a history of metastatic carcinoma. PD-L1 also was done. Reco, it was 0% again. So now we are dealing with the post-osimertinib progression, isn't it? So how you will approach post-osimertinib progression? May I ask Dr. Shaina if you can throw light upon?
So these patients, now we do not have any further targeted therapy, but these are the patients whom we have to go on for systemic therapy in terms of chemotherapy. And I think there were the trial of atezolizumab plus bevacizumab had a small subgroup of patients who had progressed on these EGFR TKIs. So that is another option which can be considered for this patient along with chemotherapy.
No, that's okay. That is about the treatment. I'm telling what is your approach, like post-osimertinib progression. What are the things you will think in back of your mind? These are the likelihood of getting these all mutations. Treatment is later on. Obviously, we can discuss about that ABCP and all those things are correct. But what will be your approach? Post-osimertinib progression, what will be in back of your mind? These are the mutations which are likely to come in the report.
So
there will be issues either with the EGFR receptor or with the non-EGFR areas. And in the non-EGFR, it could be the EGFR amplification or even the MET. They can step in. Now, this is the time to go in for a more detailed analysis or subject this tissue or subject this biopsy, whatever is available, to more comprehensive analysis. And you may get some lead out of that. But otherwise, it's a standard chemotherapy. You have to go back to chemotherapy and nothing else.
Absolutely right, sir. So we have gone ahead and we thought of all these options, that the 15% chance of MET mutation is there, MET amplification is there. There are 7% chance of C797S cis or trans enantiomers. There are isolated case reports of transformation of the histology, like you can convert, NSCLC can convert to small cell histology. There are chances of getting BRAF mutation. That's so many things which can open up. That's why this is a open field, so many things can turn around. So we have gone ahead with a comprehensive genomic profiling. We have done a foundation 1 NGS for this patient. And this is what the report came out. And to our utter surprise, this patient was having a BRAF AGK BRAF fusion. So this is a non-V600E mutation. This was the report which came out. And you can see the patient was also having a EGFR exon 19 deletion. And the therapist with clinical benefit is tremelimumab. So we know that. So BRAF V600E mutation, dabrafenib and tremelimumab is the drug of choice. But this patient was having a BRAF fusion, for which the therapist with clinical benefit was only tremelimumab. So in this patient, this is what the final outcome of the NGS report. And we have gone ahead. We know that BRAF mutation carries a bad prognosis. So BRAF V600E mutation is associated with aggressive tumor, worsening prognosis, shorter DFS, shorter overall survival. But this patient was not having BRAF V600E mutation. So this patient was having BRAF fusion. So we know that regarding BRAF fusion, we have done a little bit literature search at that point of time. So BRAF fusion is a rare yet potentially actionable resistance mechanism in the patient treated with EGFR TKI. So how do we treat these NSCLCs that have become resistant to EGFR TKI through BRAF fusion? Do RAF inhibitor works? Which type of RAF inhibitor works in, and is what the question. So we have gone into the literature and we have found out that there are acquired resistance mechanisms. BRAF fusion also is possible. So RAF proteins are serine thyroid kinase that mediate the signal from RAS to downstream MEK and ERK. And these patients can be offered MEK inhibitor like tremelimumab can be offered. So dabrafenib and tremelimumab are approved for the patient with BRAF V600E mutation. However, these combinations are very unlikely to work with BRAF fusion because dabrafenib is specific for BRAF V600E. Clinical experience treating tumors with BRAF fusion is limited. Responsible tremelimumab MEK inhibitor have shown in melanoma that this can be given to those drugs. These are isolated case reports in which it have worked. I will not go into detail. So this patient we started on a single agent tremelimumab, and patient have taken it for 4 months. Again, there was a progression. So the question which is standing in front of us is, in first line TKI, we have used lotinib. Second line, which worked for 8 months, again progressed. Second line TKI, we used osimertinib, which worked for 18 months once T790 mutation was picked up. And third line, when BRAF fusion was picked up, we started on tremelimumab. So this is a chemo-free. Patient have done so well for 8 months plus 18 months plus 4 months, nearly 30 months. Patient was chemo-free or immuno-free. And what next? Even what is to be done? So we have gone for a liquid biopsy in this scenario, but it was non-contributory. Patient was financially affordable, but we have what is to be done next. So is there any data of...
Nagendra, I have a question. How do you know that this BRAF was the driver mutation? Nothing worked. It worked only for 4 months, which is not in tune with the way the targeted therapies would work. With a PFS of just 4 months, very unlikely that this was something like a driver mutation sitting there. You don't know.
Absolutely right, sir.
Yeah.
Right.
That is the pitfall. That is the pitfall of digging deeper and deeper. Because the more you dig, you would find something, but you don't know whether that is of a clinical significance or not. And the amount of the finances, the resources, and the effort you would need would be tremendous actually to find out one such patient versus you treat 100 more patients. That's the question I'm coming back to again and again.
Absolutely right. Absolutely right, sir. It is difficult to answer this question because we don't know whether this was a driver mutation, but we have gone by evidence.
Was this a passenger mutation? Was this a passenger mutation? Not a driver mutation.
Right. Yeah. Correct. So, but there are isolated case reports which are available, like post-osimetry progression. You can have multiple different type of rare mutation also. So this was one case which requires attention, and we have treated and how this case is unfolded that after Trimatinib. So these are the options, like continue TKI beyond progression or used first line TKI or second line TKI, like rechallenge or palliative chemo. These are the questions which are standing in our mind. So we have gone ahead with chemotherapy because patient was chemo naive. Patient was starting on doublet pamidixide carboplatin based chemotherapy. Post 3 cycle, there was a partial response. Post 6 cycle, stable response. Patient was kept on pamidixide maintenance, and post second maintenance, again patient had progressive disease. So oncology, the law of oncology is that we have to keep this patient as good as possible for as long as possible. And treatment is not a treatment until it's beneficial to patients. So every patient is different. We have to take decision on individual basis. And this is a worth presenting case because stage 4 cancer with brain mets upfront, we never see this type of survival. Majority of patients will succumb to their illness within a year or 1.5 years. This patient have crossed 48 months and still hopeful and alive. And so if we can see the targeted agents, the majority of times oral survival will hover around 3 to 4 years. And only one trial, the Japanese NEJ009 study, in which Japanese chemo have gone 52 months and beyond. So that's why I presented this patient. And if we were not for the greater availability among individuals, the medicine might be as well as science, not an art. And he who studies medicine without books sails an uncharted sea, but who studies medicine without patient doesn't go to sea at all. I will like to finish off this presentation by these words of wisdom from William Osler. And if you want to walk fast, walk alone. But if you want to walk far, walk together. This is the symbiotic collaboration between the various specialties among medical oncologists, radiation oncologists, surgical oncologists, by which we can add productivity and quality of life in the lifetime lifespan which your patients can have. Thank you very much for patient listening. Thank you, Vaisar, for giving me opportunity. And thank you very much. Bye-bye.
Thank you, sir. So I think we've come to the end of this meeting. Thank you, the organizers and Dr. Ved sir, for giving me this opportunity to moderate this meeting today. And if before closing, if there are any questions in the chat box, I think we can take it up. Are there any questions that we are not able to see here?
Ma'am, currently no questions are there. So,
okay. So sir, sir, shall we close? Or any closing remarks from you, sir?
Yeah, before we close, let me thank everyone who's been part of this meeting. And my sincere thanks to Pfizer, Novartis, Abbott, and Intas Oncology for supporting us in this endeavor. And we look forward to your continuing support in future as well. Indian Oncology Foundation, Mr. R.K. Malik, all the speakers, attendees, Nirav at Mice Ideas, and my colleagues in the department, Shaina, for doing such a wonderful job, and Rajesh for the wonderful navigation of the entire process of organizing this webinar. I think we understand the heterogeneity of lung cancer. The precision oncology is there to stay. And what we say that to each his or her own, I think everybody has to own the pill or the therapy, which is due based on the molecular analysis, but the challenges are still there. The cost and chronicity, and yet no cure. We saw in the presentation by Nagendra, the elegant presentation, that yet there is no cure. You know, the amount of effort and the expense, and especially the part of the world where we practice, it's a huge challenge. The cost is always a challenge. And though these drugs are leading to better responses, duration of response, quality of life, but the chronicity still stays, and some of those side effects do stay. Take care, good night, and our next webinar will be on the lung cancer, will be on the 25th of March, focusing on immunotherapies. And we hope to have a couple of overseas speakers as well. With that, let's close this meeting, thanking everyone once again, and let's thank our families as well, who continue to sort of, you know, endure and our vagaries and have patience with us after a long day's work. And then it's almost about 8 o'clock. Thank you so much once again. Take care. Good night, and see you tomorrow back again. Thank you.
Thank you.
Thank you. Thank you very much, sir. Thank you.